So my name's Smeeta Sinha. I'm a nephrologist at Salford Royal, and I'd like to welcome you all to this e-seminar. I've got some guests with me today, so I don't know if we want to go on to the first slide. Our speaker will be Professor Philip A. Kalra, so Phil Kalra to most of us. Many of you will know Phil from the famous MRCP book that many of us used, but Phil is a professor of nephrology. He was also a lead author on the seminal Astral trial for renal vascular disease, but his expertise extends beyond that and has been involved in numerous clinical trials and academic publications over the years. So it's great to have an expert speaker talking to us about CKD progression, how we interpret those guidelines using data that we have. Our other panelist, equally eminent, Professor Sunil Bhandari from the northeast of England, and again, very acclaimed clinical trialist and academic in the UK. And I guess his big claim now is the Stop ACE trial, which I think Professor Kalra will be asking about during the course of the session today. So welcome to the seminar.
So much, Smeeta, and it's a real pleasure to be invited by the ERA to contribute to this seminar series. And you can see that the title is CKD and RAAS inhibitor optimization, and that's what I'm going to concentrate on. You can see the pictures here. I know I've been in post a long time as a consultant. It's well over 2 decades, but this is what the hospital used to look like before I got there, I have to say. And fortunately, we've got this glowing building now that's replaced it largely. But you know, have we had such glowing changes in CKD progression management? Well, let's hear. Right, these are my disclosures. And then on to the talk. So first of all, CKD we know is very, very common. This is data from the UK showing that back in 2020, we had around about 2.5 million people in a population size of 67 million who are known to have CKD. And we believe that there were at least 1 million more patients who were as yet undiagnosed. And you can see the projections to 2030 that we're expecting, maybe another 1 million people to join the CKD cohort. And this is costly. I know budgets will vary across Europe and across the world, of course, but so in the NHS, our National Health Service, our budget, I think when last checked, was something like about 150 billion pounds, a lot of money. But CKD care was at least 1% of that, and probably pushing 2%. But you can see the key point in red is that half of the funding is spent on end-stage kidney disease care, and that is obviously a minority of patients. So in the UK, we have 28,000 people who receive dialysis and round about 50,000 people who've got kidney transplants, which is nowhere near the 3.5 million that I was showing you before. But so the key point is we should, where possible, try to avoid the development of end-stage kidney failure, and hence, the topic of today's talk. And our patients with CKD do have a high risk of complications. And if you just concentrate on the left of this figure, just over here, these are people aged over 65 years. You can see that these are the top yellow are the people who develop end-stage kidney disease, and this is percentage per year. And you can see that the risk of either CV mortality or non-CV mortality is something like 13 times that of the risk of progressing to end-stage kidney failure. So, a lot of people sadly die along the way before they even get towards end-stage kidney disease. So it's a high-risk condition. And we know that from this kind of data. So looking at survival over 2 decades, going from the mid-1990s through to 2011, you can see that in yellow are the figures for women and men on dialysis. So you can see that the survival probability over a decade was only 30% and didn't change over a 20-year period, whereas some commoner cancers like breast or prostate cancer were progressively improving and certainly had much better survivals, but also that progress was being made in the treatment of these patients, like take colorectal cancer, with improvements in survival, whereas that's not been the case with our dialysis population, unfortunately. And you're all familiar with the KDIGO classification for CKD, which really emphasizes the great importance of albuminuria, high levels of albuminuria, in not only indicating a higher risk of progression of the CKD, but also cardiovascular mortality, cardiovascular events, risk of AKI, risk of end-stage kidney disease eventually, but overall mortality as well. So albuminuria is a crucial factor that we need to be thinking of. And that's why I particularly like this slide, which shows it's diabetic CKD, but it demonstrates that if we wait until the GFR has dropped to 60 mils a minute or less, so in other words, stage 3 CKD, before we assign a patient as having CKD, then at that point, the patient will have lost something like 75 to 80% of their functioning renal mass. Whereas if we use the cutoff of an ACR, so an albumin creatinine ratio, that just goes into the abnormal range, so in other words, above 3 milligrams per millimole, then at that point, the patient will have lost only about 20% of functioning mass. So that's a really important point to get across. So we should be testing with albuminuria in our patients, and not just the diabetics. So if we use diabetic kidney disease as an exemplar of how we should address CKD, I like breaking down DKD into 3 outcomes that we can look at. Number 1 would be slowing or preventing nephropathy and the development of end-stage kidney failure. And there are some well-tried and tested approaches. So obviously glycemic control was proven by the ADVANCE study to be of benefit in type 2 diabetes. More importantly was the importance of RAAS inhibition, so ACE inhibitors or ARBs, controlling blood pressure to less than 130/80, but concomitantly also, because of the effects upon the efferent arteriole, controlling proteinuria as well by reducing the glomerular capillary hydrostatic pressure. But then, of course, we've got more recent treatments that actually help in slowing nephropathy. So the SGLT2 inhibitors with DAPA-CKD, Credence, and EMPA-CKD, of course, now. And then to a slightly lesser effect, the GLP-1 agonists, liraglutide, semaglutide. And then, of course, we've got novel mineralocorticoid antagonists as well that are just beginning to push in as well in terms of slowing nephropathy. Then the other outcome would be improving quality of life. So lifestyle change is so important, taking regular exercise where possible, weight loss, fitness, and don't forget anemia management, iron and EPO for treatment of our patients, making them feel better. I don't think any of those trials with iron and EPO have ever shown a mortality benefit. And improving survival of our patients is all of the above, plus cardiovascular risk management. So don't forget the SHARP study in statins and et cetera, et cetera. And yes, so for 2 decades, we were stuck without any progress, following on from these 2 studies from 2001. So these were the RAASi and the IDNT study, published in the same version of the New England Journal of Medicine, actually concomitant with an American Society of Nephrology meeting, and basically took populations of around about 1,000 type 2 diabetics, and the patients had CKD with a GFR on average just under 60, but with a gram of proteinuria. And you can see that both irbesartan and losartan led to improvements in overall risk reduction, so doubling of creatinine, end-stage kidney failure or death of round about 16 to 20% compared to placebo, but with similar levels of blood pressure lowering in the placebo group. So really important studies, and as a result of those, these became standard treatments, didn't they, in not only type 2 diabetes, but we extrapolated the use of these drugs to almost all forms of CKD, believing that they would have the same benefit. And there are trials to show there are benefits in certain subgroups of CKD patients other than diabetes. And yes, so the SGLT2 inhibitors have come along in the last 3-4 years. In fact, it's 4 years since just about since Credence was published in 2019 April. And here's just an example with the DAPA-CKD study, looking at the combined outcome of progression of CKD, end-stage kidney failure, or renal cardiovascular death. And I'm just showing you the patients without type 2 diabetes in the study. So in the 4,000 plus patients in the study, there were around about 1,400 patients. So 30% of them had non-diabetic CKD. And you can see that the effect size was actually at least as good, if not better, than in the diabetics, with a 50% risk reduction with dapagliflozin. So dapagliflozin, with its actions again on reducing glomerular hyperfiltration, and maybe many other actions as well that we haven't got time to go into, but including sort of a reduction in inflammation, renin-angiotensin stimulation, maybe even sympathetic nervous activity as well. It's now a standard of care in our patients in slowing progression. But despite these advances, there is still residual risk. So you can see, looking at composite cardiovascular outcomes from RAASi on the left, IDNT from, as I say, 22 years ago, you can see in those studies, there was around about a 10% event rate per year. So look at IDNT in middle, 2.6 years, 24% events of cardiovascular death, MI, stroke, hospitalization for heart failure or amputation. So that is around about 10% per year. Even with Credence, we were looking at around about a 5% event rate of similar events per year. So that's 2.6 years, 12.5%. So it is about 5%. So there's still this residual risk that we would like to do something about, wouldn't we, for our patients? 5% per year for serious events. And along has come, you know, the newer mineralocorticoid antagonists, non-steroidal antagonists such as finerenone, and you'll know about the Fidelio and Figaro trials that showed in diabetic CKD that in heavily proteinuria patients there is additive benefit with this MRA on top of standard ACE inhibitor or ARB therapy as well. So that's beginning to push into our algorithms for treatment of progressive CKD in diabetics with proteinuria. So what we're hoping to do with the use of renin-angiotensin blockade, and that after all is you know, the title of the talk, isn't it? Facilitating optimized use of these drugs. We are trying to avoid the red line where with a patient with CKD, they're flying towards end-stage kidney failure. When they get into the lower reaches of GFR, then things can speed up with fibrosis, etc. And of course, with use of our medications, we're hoping to actually ameliorate, as per the yellow line, or even halt, if you know occasionally happens, the pink dotted line there with our therapies. And you know, we know this is illustrated by this, which is the DAPA-CKD eGFR outcome, and we know that in the DAPA-CKD, as in Credence as well, and in EMPA-CKD, that in the initial stages after the introduction of the dapagliflozin, you expect to see a slight reduction in GFR. We see this, of course, with ACE inhibitors and ARBs in some patients of round about here 4 mils a minute. But the key is thereafter, compared to the placebo group, there was a slowing of the loss of GFR over time, as you can see. So to a significant degree, whereas in the placebo group, you can see that patients were losing something like 4 mils per minute per year overall. So it's short-term pain with introduction of these drugs for long-term gain is the slogan that we use here. And not just because Professor Bhandari is joining us on the call, I just wanted to highlight the STOP ACE trial. Why? because it's an excellent study, and not just because it was also UK based, but it was a study that we were waiting for many, many years. You know, what do we do when GFR drops below 30 and patients are still on ACE inhibitors or ARB? Do we see a benefit by stopping the drugs in terms of improving the GFR and preventing the need for end-stage kidney failure? But on the other side of the coin, by stopping renin-angiotensin blockade, do we trigger an increased risk of cardiovascular events, for example? But as you know, and published at the ASN, commented, I should say, with the ASN last November, was this result. You can see that there seemingly no benefit from discontinuation. We'll let Sunil Bhandari maybe make some comment about this afterwards, about it, whether there was any overall benefit in terms of continuation, but certainly there was no benefit in discontinuation of renin-angiotensin blockade. So the message for my talk is that we are not only using these drugs, we're using them all the way down to end-stage kidney failure now in the majority of patients. So are there any problems with that? Well, there are, of course, in some people. And so I've got a couple of cases just to show you. So this is case one, an outpatient with 3B CKD and diabetes. One of my patients, actually, a 56-year-old man we assumed diabetic nephropathy, didn't have a biopsy, which is typical in the vast majority of patients with CKD and diabetes. Anyway, GFR 37 mils a minute, losing GFR at a rate of around about 4 mils a minute per year, a bit like in the DAPA CKD placebo arm. Urine PCR 105, so that equates to round about a gram of proteinuria per day. When teaching GPs and students, we always say that for the PCR, we're talking about the protein creatinine ratio. So we pass roughly 10 millimoles of creatinine per day in our urine. So if we multiply figures like this by 10, that gives you the overall number of milligrams per day that we're excreting. So that's 1,000 milligrams or so, which is 1 gram. Anyway, the usual potassium of this patient is 5.5 to 5.8 millimoles per litre, limited compliance with diet, key medication irbesartan in maximum dose, and that's what the trials from the RAASi and the IDDNT emphasized, that when we're using these ACE inhibitors, ARBs, we should be using them at maximum dose. This patient attended my clinic. It was an afternoon clinic. He had had a recent upper respiratory tract infection, and bloods were taken after I'd seen him. He seemed okay, and I gave him a 4-month appointment, but he was actually on his way into the hospital later that evening because the biochemist let the renal SPR on call know that his potassium was 6.3. Now, we can debate afterwards what we all would have done in this case. I probably personally would not have sent him to A&E with a level like that, but anyway, he was sent there. And this is what happened. He was admitted. He was given immediate calcium gluconate to protect the heart. He was given dextrose and insulin in the A&E. The irbesartan was, of course, discontinued, as is always the way. He has an overnight stay on the medical admissions unit, saw the dietitian in the morning. His potassium was 5.1. He was discharged and advised to see the GP 3 days later for a repeat potassium check and then recommencement of irbesartan. The potassium was 5.7, and the GP was reluctant to restart the irbesartan. So, there's one case, and we'll come back to these later. And then the second case was a lady with the cardio-renal syndrome. So she was a 73-year-old lady with left ventricular systolic dysfunction, so otherwise known as HFrEF, heart failure with reduced ejection fraction of 40%, and stage 3A CKD. She had a GFR of 48 mils a minute. She came into A&E with a 2-day history of gastroenteritis. She was hypotensive, BP 105 and 55, very dehydrated. Her regular treatment included ramipril, bisoprolol, and a loop diuretic, furosemide. And you can see her potassium was 6.7 on admission, and her GFR dropped from 48 to 22. So, an AKI here. Bicarbonate 19, glucose 5, very hypovolemic. So admitted to the medical HDU, ramipril and diuretic stopped, and that's not unreasonable here. Given calcium gluconate to protect the heart, fluid resuscitated, and including giving some bicarbonate 1.4%, and also received insulin and dextrose to drive potassium into the cells. So what about hyperkalemia? Let's just talk about that. So we know that the prevalence of hyperkalemia is pretty high. If you take all comers with CKD, then that's the reddish line, fourth one up here. I hope you can see my pointer. Round about 5 to 8% prevalence at any one time of hyperkalemia, and that's probably taking a definition of a potassium of 5.1 millimoles per litre and above. Now, many of us old timers would actually not bat an eyelid until we get potassiums of 5.4 and above, and certainly our local laboratory that Smeeta and myself utilize actually has a normal range up to 5.3 millimoles per litre. Anyway, you can see that patients with stage 5 CKD, something like 25% will have a prevalence of potassium greater than 5.1 at any time. And you can see the values for stage 4 pretty high as well, and then the other stages. And we know that there's a U-shaped curve associated with potassium. So hypokalemia itself is a risk factor, as you can see to the left of this slide. Our sweet spot potassium is, of course, 3.5 to 5.1. But then we have an ever increasing risk as the potassium increases up to well into the 6s, and then very dangerously into the 7s. You can see that certain multiple comorbidities are at increased risk. So CKD plus heart failure plus diabetes brings with it the highest risk, as you can see over here. And real world data, this is from Murray Epstein, and this is looking at hundreds of thousands of patients. I think it goes into, might even be 2 million people in the United States who were receiving renin-angiotensin blockade, and looking at what actually happened to them over a year or so's period. You can see that a high proportion who developed mild hyperkalemia, just 5.1 to 5.4 millimoles per litre, had a reduction. 38% of patients had a reduction, either down titration or cessation of the renin-angiotensin blockade. And those patients who had a potassium of 5.5 or above, it was 47%. So the development of hyperkalemia, this is the key point, will often lead to either a down titration of renin-angiotensin blockade or cessation. And just like my two cases, the danger is that these really important drugs are not then recommenced, and hence the cardiovascular risk and progression risk is then maintained in these patients. So just trying to make the issue of potassium physiology interesting to you. I think there are one or two interesting facts here. So 98% of our potassium in the body is intracellular. And remember that the intracellular potassium concentration is almost like mirrors the sodium in our plasma. So 150 millimoles per litre, whereas sodium, of course, is 140 in the plasma. And the 2% of our total potassium is extracellular. Of course, we've discussed, you don't need me to tell you what the normal range is, but that again is the inverse of what sodium is intracellularly, which is only round about 4 or 5 millimoles per litre. Now, the potassium that we take in the diet, which is on average around 60 millimoles per day, 10% of that is excreted in the feces. So remember that figure, 6 millimoles goes out in the feces on average, whereas the rest is excreted via the kidneys to maintain balance. Okay, and this just shows a little bit more about where the potassium is. I've told you, that's the extracellular space with taking 4 millimoles per litre as the potassium concentration. So that's saying that we're around about 15 to 18 litres in the extracellular space, 5 litres of course in the intravascular volume. But then if we look intracellularly, this is where the potassium is held. I'm not going to go over that, but here we see the hormones and other mechanisms to push potassium into the cells. So of course insulin, catecholamines, beta agonists, salbutamol, etc. Alkalosis, hence we use bicarbonate, drives potassium into the cells. And potassium is normally maintained at those concentrations we've talked about by the sodium potassium ATP pump on the cell membrane. Now, this is the bit that I find very interesting, because you might ask, well, hang on a sec, if only 6 millimoles of our daily dietary potassium is excreted via the feces, why do the potassium binders work? Well, the interesting thing is this. There is almost like there's a blood to gut secretion of fluid going on each day. So, well, all the time. So 3 to 6 liters of fluid are secreted from our blood space, interstitial space, sorry, into the lumen of the intestines each day. And that fluid has a potassium concentration of around about 15 millimoles per litre. So we're saying we're kicking out 45 to 90 millimoles into the gut, which could be acted upon by the potassium binders. But if we don't use potassium binder, most of that is reabsorbed, and hence we maintain balance. But the point is, if we need to get rid of potassium, the binders can get rid of up to 40 millimoles of potassium via this route. So in addition to the 6 that's passed out in the feces. So it's an important thing to think about. So current acute and chronic management of hyperkalemia. Well, for emergency treatment, you know all of this, I'm sure, but we can stabilize cardiac membranes with calcium gluconate. We can shift potassium into the cells by some of those mechanisms I've just shown you, insulin and dextrose, beta agonists, sodium bicarbonate. And then, of course, we can remove potassium from the body via binders, such as the good old-fashioned calcium resonium that is probably in many countries going to be a thing of the past. And then the modern binders, such as Potassium and sodium zirconium cyclosilicate or Lokelma, and loop diuretics. We've always, as nephrologists, got dialysis at our disposal. And then in long-term control, we've got binders, we've got diet. We can talk about that afterwards. And we've got reduction or discontinuation of the renin-angiotensin blockade, which is obviously one thing I'm trying to push that we don't do. And here are the new binders, the novel binders. The old-fashioned one, the calcium resonium, is non-selective and has got quite a lot of side effects associated. But sodium zirconium cyclosilicate is a cation exchanger, exchanging sodium for potassium. And, so some people might have some, slight concerns about use in patients who've got marked heart failure, for example. Potassium is a non-absorbable polymer binding potassium, primarily exchanged for calcium and obviously sometimes magnesium. There have been a few studies with these new potassium binders. I'm not going to go through these in detail at all. You can see that the size of these studies is relatively small. The maximum size of trial being 306 in the Amethyst diabetes study, but you can see for both Lokelma and Potassium, there have been quite a few studies to show efficacy and safety. And here's just a couple of examples. So the OPAL HK study, so this was a study with Potassium in patients who were receiving renin-angiotensin blockade and or who were hyperkalemic. And you can see, I'm not going to go into the whole detail of the trial, there isn't time, but you can see that by use of Potassium, it was possible to maintain use of renin-angiotensin blockade in 94% of patients compared to 44%, who got placebo. In the Amethyst, another jewel, of course, diabetes study, again with Potassium, this demonstrated that use of this potassium binder was successful at minimizing hyperkalemia in diabetic patients receiving renin-angiotensin blockade right out to a year. So safe use out to a year with this drug, maintaining normokalemia. And here's an example of a study with sodium zirconium, so Lokelma. The Dialysis study was looking at use of this agent in almost 200 patients on receiving dialysis who were hyperkalemic as well. So in the UK, we have this body called NICE, So the National Institute for Clinical Excellence, which provides guidance, and both of these novel therapies were reviewed by NICE. And it states Patiromer here, it's the same for Lokelma as well. So it's considered as a viable option for treating hyperkalemia in adults, in emergency care for acute life-threatening hyperkalemia, or for people with persistent hyperkalemia with CKD, provided that they were taking or eligible for renin-angiotensin blockade, and that potassium had to be shown to be above 6. And so the guidance from NICE is that if the patient is no longer going to receive renin-angiotensin blockade, then they wouldn't be receiving these drugs. The assumption being that potassium obviously fell back into the normal range. I just wanted to tell you a little bit, getting towards the end of the talk now, a little bit about our cardio-renal clinic that we've had running in Smeeta and my hospital in Salford. So between 2019 and 2021, we treated 40 cardio-renal patients. So these are with heart failure, with Patiromer largely in that particular clinic. And this is just the epidemiology. You can see that the mean age was 74 years. You can see the CKD stages down the left. So 64% of patients had stage 3 or worse CKD. 75% essentially were receiving renin-angiotensin blockade at referral, and 50% mineralocorticoid antagonists. But at first visit into the clinic, because the drugs were largely stopped as they were referred, 2/3 of patients actually had what I would class as normokalemia. And just outcomes. I think the key outcome to emphasize is this, that by using Patiromer in these 40 patients, and yes, there was some intolerance due to GI side effects in some patients, but we were able to increase renin-angiotensin blockade, so with ACE inhibitors, ARBs, and or mineralocorticoid antagonists in 88% of patients. So I think that's a really important point to stress. So let's go back to our two cases then. So if you remember, this was my patient, 56-year-old man who was admitted after my clinic with a potassium of 6.3. Again, we'll discuss afterwards whether that was a sensible thing to do. Anyway, he was discharged, and if you remember, the GP was not prepared to restart irbesartan, GP being, of course, primary care physician. And that was because the potassium was 5.7. So what actually happened to this patient? Well, he was seen in the renal clinic 2 weeks later. His potassium was still 5.7. His GFR was 33. He was started on Lokelma in a dose of 10 grams once daily. 2 weeks later, it worked. It got his potassium down to 4.9. He was recommenced on irbesartan 150. He was given sick day rules advice, meaning he was told that, if he got hypovolemic stress, for example, such as taking to his bed with the flu for a couple of days, or COVID, or having a gastroenteritis that led to vomiting and diarrhea, that he should temporarily stop drugs like irbesartan, or I'm not sure. I don't think he was on metformin. But drugs like that at that time. Anyway, 1 week later, his potassium was 5.1, and a further 2 weeks on, it was still 5.1. So his irbesartan dose was increased to 300 milligrams daily. And I've not told you there when the Kalra was discontinued, but it was a few weeks down the line. We can discuss that at the end as well. In case 2, this was the acute kidney injury patient in a lady who got the cardio-renal syndrome. Ejection fraction 40%, came in with gastroenteritis and hypovolemic, managed with fluid replacement, as well as stopping again the ramipril and diuretic. And what further management should be undertaken? Well, what happened to this lady? Well, she was treated with Patiromer, this lady. I think it was because of her heart failure. She was given a drug that would not exchange sodium. and urine flow resumed, after her rehydration. She got cracking with a good diuresis by 48 hours. Potassium was down at 5.7, and she was discharged at day 3, taking Potassium, was seen in a heart failure clinic by the specialist nurses at 1 week. Potassium was 4.9. Ramipril and furosemide were recommenced. Potassium was continued, and then seen in the GP clinic 2 weeks later. Potassium satisfactory at 5, and it was possible to withdraw the potassium binder. So you'll be pleased to know that we're at the end, and this is the last slide. So here's a summary, and I've put some points for discussion. So in summary, slowing of EGFR decline and decrease in cardiovascular events are key outcomes in CKD, and renin-angiotensin blockade with ACE inhibitors or ARB and or mineralocorticoid antagonists are cornerstones of our treatment of these patients still. Even with the SGLT2 inhibitors, which have made a major advance following Credence, DAPA-CKD and EMPA-CKD, there remains a significant treatment gap. Novel potassium binders can enhance optimization of the renin-angiotensin blockade to continue this therapy at optimal doses in patients who otherwise would develop hyperkalemia. So in terms of points for discussion, these are some of the things we could talk about, but I'll leave that to our chair. But I'll read them out, Smeeta, anyway. So, what is the place for MRA therapy in CKD patients? What dietary controls should be encouraged in hyperkalemia? That's contentious. Do SGLT2 inhibitors coupled with renin-angiotensin blockade reduce likelihood of hyperkalemia? How long should potassium binders be used in a chronic outpatient setting? And also, can we talk about regimes for withdrawal of binders? So thank you very much for listening, and I will stop sharing at this point. There we go.
Great, thank you so much, Phil. I mean, you covered an awful lot in that presentation, from the management of progressive CKD to the clinical trials, and then also how to manage some of the complications, notably hyperkalemia. And you also did my job for me by giving me some questions, so thank you. As it happens, we've got really good engagement from the group, so still send in your Q&As, but a lot of the questions that you've asked have also come up in the chat. So I think maybe we should just start with around CKD management first. So one of the questions was around, which trial do you think has been the most important trial around management of CKD? What are the first steps that you would put in place to sort of attenuate progression? And has that changed? A nice, easy question to start.
Yeah, no, well, is it easy? but no, thank you. So I would have to say that though we love DAPA-CKD and EMPA-CKD and et cetera, that I think the IDNT trial and renal trials of 20 odd years ago made, we had nothing else for 2 decades, and we extrapolated the results into all manner of other CKD patients. So I think I'd have to say would be those, because we've followed on from that, haven't we, renin-angiotensin blockade? So definitely one or other, probably, and I personally like irbesartan, and so I'd probably go for IDNT. There you go. I don't know if Sunil's got a different opinion. Stop ACE, of course.
Stop ACE.
Just slightly, I'd have gone a bit further back to 1993, Lewis's first trial with captopril, before the ARB trials, because that really was the landmark trial showing the ACE inhibitors reduced it, and then they moved on to look at ARBs as well, and clearly both those trials were Lewis trials. So I'd say the 1993 trial, then the 2001 trial.
Yeah, no, that was in type 1 diabetics, wasn't it? So
yeah, it was.
Yeah.
But it just showed the huge benefits of ACE inhibitors in renal, and first, actually, one of the first papers on renal outcomes.
Yeah, no, good point. Yeah. It was a small trial as well, wasn't it?
Yeah.
So I guess our take-home message is, don't forget the cornerstone of nephrology, which is those ACE and ARBs. So even though we might have the new stuff, it's not, we mustn't forget. And there certainly has been a lot of questions around that. So thank you very much to Dr. Ramadan. I mean, you've sent in loads, so they're great. So I might do quick fire questions. What do we think about ACE inhibitors in advanced CKD, in proteinuric and non-proteinuric? And I guess I'm going to ask this to Sunil, because obviously the stop ACE was very much about advanced CKD. And also, do you think the evidence is good enough for ACE inhibitors on dialysis? So 2 questions, all about advanced CKD and ACE and ARBs.
So clearly we didn't look at dialysis, so I can't comment on that, but certainly the data was pretty conclusive that continuing ACE or ARBs in advanced CKD was not detrimental. Probably almost slightly beneficial. ACEs slightly over ARBs. If you looked at the progression, if with those who stopped, it was worse, but it wasn't significant. In terms of other benefits, there was no adverse cardiovascular risk. And so what we demonstrated, remember, we stratified for proteinuria, and we find no difference when you stratify for proteinuria. And we stratified for diabetes. So there was no difference if you were diabetic or non-diabetic. So I think in both groups of those patients, it's beneficial. The other thing which the trial demonstrated was in those who stopped drug, blood pressure and proteinuria actually went up. So even if you wanted to control proteinuria and blood pressure, you should continue the drug as a beneficial effect without any detriment. So that's what I think the trial shows. In dialysis, and Phil might have know better than I do, but there's very little data in dialysis patients of benefits. I don't think there's any randomized controlled trial that I'm aware of.
No, and I'd just add to that you know, if a patient made it their way on to dialysis, a bit like the statins story, really, isn't it? That you probably wouldn't start, but if they then had a cardiovascular event, you know, then and the ACE inhibitor or ARB was justified because of that, like a statin, then you would start the drugs for that reason, wouldn't you?
Yeah, absolutely.
Yeah, I mean, there's an interesting scenario that's just come in, which I'm not sure if Stop ACE addresses it really, but it probably does. Should I stop an ACE inhibitor? I think probably the other studies address this as well. Should I stop an ACE inhibitor in a type 1 diabetic who's 32 years old, whose GFR has gone from 23 to 12 over a short period of time? They've got heavy proteinuria, bad BP, but no hyperkalemia.
So the 2 things you mentioned, he's got bad blood pressure and proteinuria. So the ACE stopping will be worse for those 2 things alone. So I would say based on our study, no, and there was type 1 diabetics in the study, but not a huge number. If you looked at the data, there was only a small number, and we looked at we stratified actually for the different types of diabetes in the secondary analysis, and we didn't see any difference whether you're type 1, type 2, or non-diabetic. So I would say I would continue it for the benefit of blood pressure and proteinuria, as well as the cardiovascular protection.
Yeah, I think I would as well. Can I ask Phil a slightly meaner question then? So we've talked about a 32-year-old. I'm going to take you the other way. So if you've got someone who's older, so let's go for 90. Yes, 90 years old. Where's that question gone? I've lost it anyway. Someone who's 90, who's got slowly progressive CKD, so not like this patient. What do you think the role is there? Do you think there's still a role for, and not much proteinuria for ACE inhibitors and for SGLT2 inhibitors?
Well, it depends on their physiological age anyway. You know, that's
of course.
Chat that one out. But yeah, I would still say that these drugs are meaningful even in that age group. If there's proteinuria and they're slowly progressing anyway, and you know, to control blood pressure, I still personally would use them. Clearly, if I'd stop other antihypertensives to avoid falls, etc., etc.
Yeah, frailty. Yeah.
But actually, what I was just going to chip in on with your question to Sunil was to talk actually about delta GFR, because I didn't really go into that in the talk, and it gives an opportunity because you know, our clinics, we would be happy generally, especially with diabetic CKD, and they're proteinuric, if we're losing GFR at under 2 mils a minute per year. But we do recognize that there is sadly a subgroup of patients with nephrotic range proteinuria who belt down towards end stage kidney failure, whatever you do. And I've seen people go from a GFR of 90 to be on dialysis without any other cause for it, no obstruction, you know, no renovascularization, in 3 years. When they've got like 15 grams of proteinuria, and that shouldn't be forgotten, really.
Yeah. I think we all feel that we need to be using these drugs more or less, don't we? And Stop ACE does support us with that, but also the binders. So it might be a good opportunity to bring us on to, because there's a lot of binder questions. And your GIT potassium loss has raised a question. So I'll start with the physiology bit. Does the GIT potassium secretion or excretion change as CKD advances? Ooh. Do we know anything about that?
So I've done research on this one.
Oh, there you go, Sunil. You take it.
PhD.
So, Smeeta, I was going to say that of course I know that, but I'm going to defer this to Sunil.
So people don't realize in the colon you've got MAXI-K channels, and they are upregulated as you get renal failure. That's why people adapt in renal failure to tolerate potassium. So what happens is your GI loss of potassium can actually go up to about 20% as you get advanced kidney disease, purely from the upregulation of MAXI-K channels in the colon. So if you go back to the decades, one of the treatments of hyperkalemia was to induce diarrhea, because that stimulated the MAXI-K channels, so you lost potassium that way. Not a great treatment for patients. They don't like it very much. So the binders really act on that as well in terms of helping us. So there is some adaptation in chronic kidney disease.
Wow, so you're bringing in your PhD. Gosh, Sunil, breadth and depth of knowledge. So looking at the more novel things compared to diarrhea inducement, if you had to pick one, what would you pick? And does the presence of heart failure influence your decision? So I might ask Sunil that one, seeing as he is the potassium expert from the gut. How about the heart?
In terms of which binder I would use?
Yeah, does it make a difference, or are you happy with both?
It's difficult. I mean, it's difficult because there's no head-to-head studies to say. I mean, you've got one binder which is sodium-based and one which is calcium-based. And, giving somebody a sodium-based binder, potentially you're increasing the sodium load, which might increase the potential for fluid retention. And I think that's an important consideration. But I can't quote you a study giving head-to-head saying it definitely does. Clearly, they both have similar effects on potassium binding. They drop it by about 0.4 to 0.5 millimoles on average when you bind them. And that's consistent if you stay on it, but you get rebound effect when you come off it.
Did you notice anything in your trial, your real world practice, Phil, in the clinic, the cardio-renal patients that you had on? Because you used both drugs, didn't you?
Well, we chose Potassium based upon, the fact that there's the sodium exchange with Lokelma, rightly or wrongly, we largely did. I think there was only one patient in that 2-year period that I described where we had to switch to Lokelma because the Potassium, even at double dose, wasn't controlling things. But in terms of so I can't comment about the sodium load really from that experience. But it was successful, as you saw, in 88%. We're able to have an increase in the RAAS inhibition.
Okay, great. And then so moving into the emergency room scenarios, because you described that's sadly where a lot of people end up. One of the questions was, well, when somebody comes into the emergency room, do you think they should be starting the potassium binders at that time? Do we need to extend our education out so that they start it there and then? And do you have a preference on which binder in the emergency setting? So I'll ask Sunil because I know he's just come back from the ward, so this should be.
So I have a conflict of interest. I've written the protocol for our hospital, and the protocol states that if your potassium is over 6, in fact, you should start the binder. Over 6.5, you should start the emergency treatments plus give them the binder. In our hospital, we use Lokelma because it works based on the data slightly quicker, but both are good. So that's in our protocol now for potassium 6 and greater.
Do you stop the ACE ARB then, or do you say carry on the ACE and ARB and then just whack that in as well?
So not being there 24/7, I've got no control over what they do. I suspect they do stop it, and it would be not unreasonable because you probably couldn't be defended for not stopping them in the short term. But the key is restarting them, and that's where we fall down badly. Is restarting them.
Yeah. Okay, and then I guess they come back to your clinic, Phil, and you've shown that you can carry them on long term. Do you think the SGLT2 inhibitors, because we're using more of those, do they affect the potassium as well? Do you think we see less hyperkalemia? You know, there's discussions around that, isn't there?
So theoretically, you would perhaps expect that. You know, you've got an increased sort of, you know, natriuresis, haven't you? Clearly, as well as the, you know, removing glucose out of the urine as well. Bigger urine flow, and obviously more probably stimulation of aldosterone further down the nephron. Again, I've not seen any data. We'll have to wait for some real world evidence, because clearly the trials that were described, those short, some of them, well, one of them was 52 weeks, but those shorter studies were probably in the era where most of those patients wouldn't have been receiving the SGLT2 inhibitors. But I would expect that there is probably a tendency for less likelihood of hyperkalemia.
Yeah, because hopefully we'll have patients on both, won't we? Which then brings in the third agent, MRAs. What do you feel? What do you think about therapeutic use of an emerging drug, finerenone? It's available in some countries, not in all. What do we feel about finerenone? You flashed up the data earlier. Yeah,
so clearly we've probably had limited use of you know, the original MRA, of course, spironolactone, and then subsequently eplerenone in our clinics, in CKD particularly, unless, of course, you have a sideline of resistant hypertension, where you're managing patients with primary hyperaldosteronism. But certainly the trial data from Figaro and Fidelio would be supportive of introducing an MRA like finerenone. Well, that's what the trial was, in the patients who have got marked proteinuria and rapid progression of CKD despite optimal blood pressure control and use of renin-angiotensin blockade at maximum tolerated dose. You know, and now obviously with thrown in with dapagliflozin or empagliflozin as well. Yeah, so I'd be keen to try, though it's only just really become available, hasn't it, in the UK?
Exactly, yeah, and that residual risk is there, isn't it? And I guess that's probably going to bring us on to questions down the line, which is, you know, when we have all these drugs, should we be not stop ACing, stop MRAing down the line? You know, what when we look at deteriorating GFR, advanced CKD, fine, Sunil, you have answered the stop ACE question. Do not stop the ACE. Do you think we'll be looking at stop SGLT2I, stop MRA, or do you think we're okay on those fronts? Are you going to run another trial?
So what if you think about SGLT2s, what do the guidelines say? I'm sure you know we're just about to submit the revised guidelines based on EMPA-Kidney from the UK Kidney Association, which I co-author on. And we've decided to drop the GFR to, you can start them down to a GFR of 20, from 25 we were from DAPA CKD. And the recommendations are to continue them until you require dialysis. So, because we believe there's benefit there. And so I think that's really important. The interesting is, one thing I think people need to realize is that in terms of how you use them, we are actually recommending do not check the kidney function when you start them, because it will get worse and it might make you stop them. So that's rather than what you do with ACE numbers, where you're meant to check it at 10 days or 2 weeks. So we're recommending you don't check it because of that well-recognized drop. For MRAs, I think that's difficult because of this idea about the antifibrotic effect and the long-term benefits. So I think let's watch this space, because they have other benefits as well. Again, this thinking about cardiovascular, and it's this sort of the pathways you think about.
So now, why would you recommend discontinuing the SGLT2 inhibitors when you hit dialysis? Don't you want to try and preserve, you know, residual renal urine flow?
And the cardiovascular stuff.
Absolutely. So I guess we're purists when it, you know, with Will Harrington being the lead for the guidelines committee, we don't have any evidence to make a comment. So we can't make a recommendation, which is a fair thing. You know, we have to base it on what the evidence is. 1,073 papers published on SGLT2 so far. Wow.
So I guess we've talked about hyperkalemia and largely talked about the benefits in optimizing renin-angiotensin system inhibition. Do you think we should be doing the same for MRAs when they're widely available? So should we be using potassium binders to make sure patients remain on MRA, not in the heart failure setting? Phil, you do the MRC clinic, so have you done that already?
So I haven't yet used finerenone, and I've got very few patients who are on spironolactone. They would be patients who've got very, very severe hypertension. And, you know, obviously renal nerve ablation went out with the baby in the bathwater, didn't it? So in those patients, yeah, I mean, I can foresee use of finerenone and the need to use a binder with them. Yeah, absolutely. Yeah, if it's almost the case that you're just talking to Sunil about before, the 32-year-old and that rapid decline of GFR. You know, you need to maximize all the therapies, you know, obviously rule out other potential causes for that. But, you know, if they're grossly nephrotic, you need to just throw everything you can at them, and you may well need potassium binder to support you.
Right. Okay, so I think I will, fantastic discussion, great questions. I'm going to wrap up with Dr. Bova's comments, which is these are great times to become a nephrologist, because for once we've all of a sudden got a whole set of trial data that are actually clinically relevant and help us to manage our patients, and hopefully fewer patients on dialysis in the future. So thank you so much, Professor Bhandari and Professor Kalra, and thank you to the attendees.